Now, tying all of the medications and different effects together, we're going to look at how nurses are going to manage the side effects. So, first of all, we know that dry mouth is a side effect of a lot of these. And so, for dry mouth, we can actually give ice chips and sugarless candies to our patients to help stimulate their salivation. You also might give xylitol, which is a moisturizing supplement, which may help as well. When it comes to urinary retention and hesitancy, we want to be sure to check for bladder distension. Run warm water or water or a moist towel over the abdomen in order to help them to be able to urinate. And if they cannot urinate, we may need to cath if there's no results. So you may see many of the med surge types of things going on a psychiatric unit if they're complaining of urinary retention and hesitancy, such as a bladder scan followed by voiding, followed by another bladder scan to see if there is, urine being retained in the bladder with urination. And again, we cath people on the psych unit too, but usually it's a straight cath in order to manage urinary retention and hesitancy. Constipation may occur, so we want to increase their fiber, their physical activity. We want to give stool softeners, prune juice, laxatives if necessary in order to keep that at bay. Of course, the best way to deal with it is with fiber and physical activity, and then we will gradually step up our interventions as necessary, but obviously we don't want to use laxatives long term. Blurred vision may occur. Now, this is a symptom that can improve after a week or two. And so in the meantime, you may want to use magnifying or reading glasses, but if it continues, we may need to consult the provider for medication changes because this is not something someone should have to live with long term. Dry eyes can occur, in which case we may use artificial tears. Make sure that we instruct our patients to avoid wind and use a humidifier at home. Sexual dysfunction may occur, and they may need a different medication for this. Lubricants for vaginal dryness may be used if that is part of the sexual dysfunction. Anticholinergic toxicity may occur, which is where there is reduced or absent peristalsis, which can lead to a bowel obstruction, urinary retention, mydriasis or pupil dilation, hyperpyrexia without diaphoresis, so basically they're hot but they're not sweaty, so hot, dry skin, delirium, tachycardia, unstable vital signs, agitation, disorientation, hallucinations, reduced responsiveness, worsening psychotic symptoms, seizures, and repetitive movement of the motor system. And so with anticholinergic toxicity, obviously we're going to be discontinuing and seeking ways to manage the symptoms that they're having as a result of this. And of course, that is where we're going to hold all the meds. If that occurs, consult the provider, use cooling blankets, alcohol or ice bath to cool them down if there's hyperpyrexia, catheterize them if there's urinary problems, administer benzodiazepine or other sedation. And of course, a lot of these are as ordered, so remember, these aren't independent nursing actions. Don't know how to pronounce this one. Physostigmine may reverse anticholinergic toxicity. We don't usually give that in the psychiatric unit. It's going to be more of an emergent situation drug. And you're going to evaluate for worsening of psychosis because you've had to discontinue the offending agent. Here's a little more about side effect management. We do have that pseudo-Parkinsonism that is going to occur. And that's one of those EPS type reactions that's going to occur where they have a mask-like face. They're going to be stiffed. They might have a stooped posture or a shuffling or fenestrated gait, which I hope I will show you when we cover schizophrenia spectrum disorders. Bradykinesia, drooling, tremor, pill rolling, finger movement. That's that pill rolling finger movement we already talked about. Dysphagia, and a reduction in spontaneous swallowing. And so interestingly, with lots of psychotic disorders, especially schizophrenia, we already see difficulty in swallowing. So it is very important that we understand how to do a swallow screening, which you'll learn in your adult health courses, and make certain that it is not dangerous for our patient to swallow because the risk of aspiration is high when you have individuals who are having difficulty with this. When we are having these pseudo-Parkinsonism types of symptoms, pseudo because they're not real Parkinson's disease, but they're reduced by the medication, we want to administer anti-Parkinsonian agents. And so when you see an antipsychotic, also known as a neuroleptic medication, we are going to administer agents such as trihexyphenidyl, which is artane, or benzotropine, which is cogentin. If it's intolerable, like they're really having difficulty with these Parkinsonian type symptoms, if it's intolerable, we do want to consult the prescriber to see if we can change the medication dose or something like that, or change to a different medication with less of a profile for causing these types of symptoms, such as a second generation versus a first generation antipsychotic. We also can provide a towel or handkerchief for the individual to wipe excess saliva if this is part of the problem, and teach them how to reduce their fall risk when shuffling or the stooped posture are part of their issue with their pseudoparkinsonianism symptoms. So, another nursing action is that we need to be aware of acute dystonic reactions that can occur with administration of antipsychotic medications. And these are going to include things like painful contraction of muscle groups, spasms of muscles, which are going to cause that backward arching of the head or neck, that torticollis that we saw earlier in a slide, and the spine as well. The eyes are going to possibly roll back, meaning you like it looking up in the air, and that's an oculogyric crisis. And they could have laryngeal dystonia as well, and this is the most dangerous because it could threaten their airway. But it is rare, so if they start to complain of their tongue being thick or protruding, or you start to notice that they're having trouble with their speech, this could indicate that they're having that laryngeal dystonia that's going on. So we do want to manage it through monitoring the airway. An artificial airway may be necessary, but usually if we intervene early enough, it won't. We want to reassure the patient because this can be very scary for them. And we want to administer those anti-Parkinsonian agents such as the Artane and the Cogentin. And the response time to these is usually going to be 15 minutes or less. Another medication that you have very commonly available on the unit is going to be diphenhydramine or Benadryl. And this can be given either IM or IV, and also takes about 25 to 30 minutes to work. So it's a little bit longer to work, but it works quite well. Now, most of the providers, when they're administering first-generation antipsychotics, because the acute dystonic reaction is most common with first-generation antipsychotics as opposed to second, they're often going to prophylactically treat someone with an oral anti-Parkinsonian agent, such as Artane or Cogentin or Benadryl, because this is going to, number one, keep the acute dystonia from happening, but number two, it's also going to control those extrapyramidal symptoms that are so bothersome for patients who are on these first-generation neuroleptic antipsychotic medications. The big thing is with this type of patient, we are going to want to stay with them and provide comfort and support and assist them to understand the event and avert distrust of medication, because what happens is you have all these side effects occurring, people aren't going to want to take their medications. So if we can help to minimize that through staying with them and reassuring them and helping them to understand it, it's going to be quite helpful to the patient. Now, let's talk a little bit about more side effect management. The akathisia or inner motor restlessness is going to be quite a possible side effect that they may have with these medications. And so when they have a lot of akathisia, we might want to consult for possible medication changes and definitely seek an order for these anti-Parkinsonian medications that can help with that if someone is experiencing it. Propranolol or lorazepam or diazepam may also help with this inner restlessness that occurs. And so propranolol, of course, is a blood pressure medication, which has some anti-anxiety properties as well. Lorazepam is also Ativan, which is a benzodiazepine, so not good for long-term use, but for short-term. Also, diazepam is also a benzodiazepine, which is Valium. Relaxation exercises may help, and it usually subsides when the agent that is offending, that's causing the akathisia, is actually discontinued. Now, tardive dyskinesia can be a real problem, and this is something that can become permanent, and usually it's going to occur more frequently with the first-generation antipsychotics. The way I've heard it described is that the antipsychotics have a high affinity for those dopamine receptors, and when enough blockade of those receptors occurs, it becomes permanent, as opposed to the second generation, which doesn't have as high affinity, and they fall off those receptors more easily. But with tardive dyskinesia, we are going to see some unusual movements. There have been a lot of commercials running for this for tardive dyskinesia lately, so you may have seen some of these. But what you're going to see is you're going to see people who have either maybe a protruding, writhing tongue, blowing motion, lip smacking, or facial distortions, such as facial tics and distortions of the face. You are going to sometimes see chorea, which is a rapid, purposeless, and irregular movement. You may see athetoid movements, which look kind of like a serpentine kind of movement, like they're moving kind of like a snake in their body. You may see neck and hip movements and jerks, such as rocking or twisting pelvic thrust in the trunk. And 20% of our patients who are on this longer term, on these especially first generation antipsychotics longer term, can start to have some of these symptoms. So there is a scale that we're going to learn when we talk about schizophrenia and some of the other psychotic disorders known as the Ames scale, which is an abnormal involuntary movement scale. And we should be screening using this type of device at least every 3 months or so to monitor for the development of the tardive dyskinesia. Now remember, EPS symptoms are one thing, but tardive dyskinesia is a progression of that which becomes more permanent. There are some medications that are out to treat it. One is venlabenazine, which is Ingreza, or deuteratribinazine, which is Austedo. They're really hard to say. And so we are going to administer those as ordered to help with this. Discontinuation, unfortunately, with tardive dyskinesia is rarely going to relieve the symptoms, and the movements may greatly stigmatize individuals who suffer from psychotic disorders and are already stigmatized already because it is such an unusual appearance. In fact, we'll watch a video with a fellow named Jeff who had developed tardive dyskinesia. He talks about how the antipsychotics were miraculous for him, but that now, he's on a bus or something and children will stare at him and people will look at him and he feels very stigmatized because of the tardive dyskinesia that has developed. So we really want to provide support to our patients that have this and teach them, if at all possible, to conceal, such as, you might conceal it by holding one hand with the other or things like that. So this concludes our antipsychotic series of quick medication facts, and they are anything but quick. But hopefully they will provide you with the information that you're going to need in order to be able to know about the medications you need to know for the mental health course and be able to address these appropriately when you have these problems with your patients. Thank you for listening.